And I'd like to welcome you to today's Medical Center Hour, which is combined with the Department of Medicine's Grand Rounds in a program entitled Reducing Overtreatment in the Era of Healthcare Reform. I'm Marcia Day Childress from the Center for Biomedical Ethics and Humanities. And we produce the Medical Center Hour, and again this week we're doing this in tandem, happily, with the Department of Medicine. Healthcare information can confuse doctors and patients alike. What are the risks and benefits of tests like mammograms, aggressive blood pressure control, of EKGs, of lung cancer screening, of heart stents? When patients can't accurately answer these questions, they can find it difficult to have sensible conversations with their doctors about their care. And lack of comprehensible medical information not only interferes with shared decision-making, but can also lead to overscreening and overtreatment, with deleterious consequences for patients, as well as for the healthcare delivery system and for medical system reform. Indeed, today, overtreatment as a result of flawed decision-making drives a lot of our system's low-value healthcare costs. In this program today, internist Andy Lazarus and scientist Eric Rifkin join us to assess this challenging situation. They will then present as one solution a novel decision aid that they have developed called a benefit-risk characterization theater. They offer their decision strategy tool as a way to convey health information more simply, factually, and in a non-numerical format, so as to explain the risks and benefits of some common medical interventions. They'll demonstrate this approach, and they'll discuss the potential for it to improve healthcare delivery and improve patient, and I dare say physician satisfaction, and to reduce overtreatment. Andrew Lazarus, who's on my immediate right, is co-founder of and a partner in Personal Physician Care, a primary care internal medicine practice in Columbia, Maryland. Eric Rifkin, on my far right, is an associate research scientist with the Department of Environmental Health and Engineering in Johns Hopkins University School of Public Health. He also heads a Baltimore-based environmental consulting firm, Rifkin and Associates. Together in 2015, Andy and Eric wrote the book, Interpreting Health Benefits and Risks, a practical guide to facilitate doctor-patient communication. Dr. Lazarus is also author of Curing Medicare, a doctor's view on how our healthcare system is failing older Americans. It was published just last year, and you'll find copies of it available for sale in the VA bookstore just outside the upstairs door to the auditorium. Before we start, let me say that both speakers have signed disclosure forms and neither had disclosures related to this program. So I'd like to welcome Andy Lazarus and Eric Rifkin, and in an hour in which they will tell us some things and you'll get to talk to them as well. Welcome.
Thank you. Thank you. It's great to be here. I did my residency here. How long ago was it, Mo?
23, Dave.
23, a long time ago. Several of the people that trained me are here. Jerry Donowitz is up there, Gene Corbett, Dan Becker. They all look exactly the same. As I get older, they look younger. And Eric and I have been working together for several years when we wrote this book. Eric had written a previous book where he introduced some of these theaters, and it really changed the way I thought about healthcare and medicine. And I adopted those into my practice. And since we've been doing this, we've been approached by a lot of different groups, from insurance companies like AHIP, which is the major collaboration of insurance companies, to AARP, to various academic centers. We're going out west to do a keynote at a self-insured institution. So, a lot of people are very interested now in this era of healthcare reform in coming up with some kind of system that will enable much more sensible decision-making. So we just wanted to share that with you. So the challenge a lot of us know about, the Institute of Medicine estimates that every year we waste $750 billion in medical care that is useless. And just to give you a sense of what that means, the entire Pentagon budget is about $550 billion. So just the amount of waste in medical care is bigger than the Pentagon budget. 40% to 50% of interventions that we do not help people. They're considered low value. And there's a lot of strong pressure on the community to change this, but very few ideas have come out to say this is what we need to do. This cartoon explains what part of the problem is. A man with an arrow in his head, and the doctor's ordering a bunch of tests to figure out what's wrong with him. And that's often what we do in medicine. If anyone has not read the article by Gawande in the New Yorker called Overkill, he's the author of Being Mortal. It's worth it, you can get it online. And he defines what low-value care is and gives a lot of evidence of how much low-value care there is. Low-value care is care that either does not help people or actually can harm people. And a lot of what we do falls into that category. A lot of that is derived from what we do in the hospital. We have a plethora of specialists in this country that are responsible for a lot of undervalued care, a lot of high technology care. And our country is moving more in that direction. And as we're thinking about why healthcare costs so much, we're not looking at any of that. What are the barriers to actually doing something about this? The insurance payment system is one of the biggest barriers. Our insurance payment to doctors is derived by a small committee that meets secretly once a year called the RUC committee, and that determines what doctors get paid for what they do. So if a doctor gets paid $1,000 or $2,000 to put in a stent, and another doctor gets paid a couple $100 to talk about everything you could do to avoid the stent, that formula is derived from this committee. Patients also don't have access to accurate data. The data they get is from drug ads, from newspapers, from their doctors. The doctors themselves often don't get data from anything that's beyond those sources either. So patients, and my patients, I'm just a plain old private practice doctor. I have no academic affiliations. I see patients 5 days a week, and my patients are struggling to find information all the time. There's also inherently, in anything we do in medicine, a lack of certainty. A lot of times as doctors, we like to go in and be very declarative and say, this is what you need to do. You know, you need your mammogram, you need your colonoscopy, we gotta get your blood pressure down. But even in the most basic interventions that we explain to our patients, there's not a lot of certainty. For one patient that might be useful, for another patient that's not. There's a lot of variability from patient to patient. Often when there is uncertainty, it's the knee-jerk response of doctors just to do a lot of stuff. So it's a lot easier for me to order a bunch of tests than to explain to patients why I shouldn't be ordering the test. It's much quicker for me. So when this patient asks why I need 3 CAT scans for a cold, the doctor says just do it. In my first practice I was in out of residency, we owned our own lab, and the head doctor of the group told me, he said, look, order labs on everyone. They'll think you're doing a lot of stuff for them, that you'll get them out of the room quicker and we'll make money on the blood work. And he really believed me. So I think we can convince ourselves to think this way. Quality indicators. We are now being judged by what's called quality and value. But quality is a very 1984-esque concept. Quality means we follow a bunch of very set parameters that we have to insist all our patients do. So for instance, if I talk to a patient about a mammogram and explain the pros and cons of the mammogram, and the patient decides not to get the mammogram, I'm going to get an F on my quality indicators. To talk to a patient and have them make their own decision will hurt me. So it's much more sensible for me to just tell a patient, as this cartoon does, please don't waste the doctor's time with questions. Just go and tell them what to do. There's some groups, like there's a group in Boston called Care That Matters that has looked at several of these quality indicators, especially the ones in Blue Cross, and we're now looking at ones in Medicare. And the amount of them that actually have strong scientific data behind them are minimal. And if you look at that site, Care That Matters, they have a red light for quality indicators that cause harm, yellow light for ones that are neutral, and green light for ones that actually have some good evidence. And there's one green light indicator. But yet that's how we're getting paid. If anyone hasn't seen this book, it's a worthwhile read. Michael Lewis is the man who wrote Moneyball and The Big Short, and he's talking about 2 Israeli psychologists who talk about how we think and why we're not rational creatures in our thinking. And it's really important when you're talking to patients, or as a patient, when you're hearing information, to know our flaws. So first of all, we have a very poor understanding of math. When people throw a lot of numbers at patients, the patient's eyes tend to glaze over. And it's very difficult to accept a big number. We in fact, when I talk to patients about numbers, the bigger the number is, the more they're just going to start staring at the wall. So when we talk about risks and benefits, using numbers can sometimes be an impediment. Anecdotes trump statistics. We know that when people demand antibiotics for a common cold, and we give them all the evidence that antibiotics don't work for a cold, they'll say, yeah, well, it works for me. Or, my aunt gets antibiotics all the time and it works for them. The statistics are meaningless. In this book, they talk about a study they did where they tried to track arthritis and weather, the correlation between arthritis and weather among a big cohort of patients. And there was no correlation. It was a scattergram. The weather had nothing to do with arthritis. So they brought that information back to specific people in the study and said, look, there was no correlation between arthritis and weather. And they would all say, yeah, that's not true. On Saturday it was raining and I really hurt a lot. So they point to that one day, and that means more than the actual facts, even though they were involved in the study. Single events carry weight. We know that in a non-medical way, the country's been growing jobs, about 200,000 jobs a month, but when 600 jobs are saved at Carrier Plant, that seems to have a lot more impact than all those 200,000 jobs, because those big numbers just get lost. But if you could point to one single event, that seems to be more important. And people are also willing to gamble if the gambling is to prevent a bad outcome. So often when things are presented, and you'll notice this in medical presentations, they're presented that, we could prevent you from having a stroke if we do this. We could prevent you from falling down or breaking a hip if we put you on this drug. It's always in the negative. The example they use in the book is if you're given a choice of either having $500 taken away or 50% chance of either having no money taken away or $1,000 taken away, most people will pick the second option. They would rather take a chance than just have $500 taken away. And so it's really important when you talk about any kind of medical intervention that you do something that is non-numerical, that is very familiar, that it's something that people could relate to. And that's one of the ideas that we had when we came up with the theater. So there's a lot of misinformation. We all know it. We're getting pounded by very inaccurate information that's in the newspaper, that's in pharmaceutical ads, and that to us is one of the biggest barriers of why we cannot have healthcare reform that's meaningful.
Thanks for coming. Andy and I always dress a bit differently, and I think it has to do with our backgrounds a little bit, but I'm not entirely sure. So Andy mentioned a number of barriers, and how do we overcome those barriers? And I thought I would quote a line from a recently new Nobel laureate, and the answer is blown in the wind. And that particular phrase has a lot of meanings, but in this particular context, we all know about the need for shared decision-making, and we all know about the importance of empowering patients, and we all know about why these things are not happening and the value of decision aids, but the progress has been glacial. And people are trying, but they're not quite getting there. And so one of the reasons they're not getting there is because doctors in general perhaps don't understand risks and benefits as well as they should. A recent article in JAMA, it was in August of 2016, basically said that it was done at the University of Maryland School of Medicine, and over 79% of the doctors weren't really sure about benefits and risks, and they overestimated the benefits of intervention. And most respondents weren't confident about their knowledge. And as you can see in the last bullet, studies show that patients consistently overestimate benefit and underestimate harm. And this is generically the case. And while this was done at the University of Maryland, the chances are relatively good that similar numbers could be found at medical schools throughout the country. Perhaps this is the one exception, but it's been our experience that indeed is the case. So So what really are the problems and how can they be addressed? So one of the things that should be noted, and it should be given a great deal of importance, is the concept of relative and absolute risks. And risks are also always, given to you by pharmaceutical companies and then reported in the newspaper in relative terms. And we will explain that in a moment with a video we have, but doctors should always know the difference between relative and absolute values. And in our view, if you're communicating with patients, it is absolutely necessary to use absolute values rather than relative values. And the reality is that while high-value care has been adopted as a professional responsibility, the story of how this is implemented in practice is yet to unfold. So what do we need specifically to move ahead? What is the path forward? And how can we change things rather than my continuing to tell you that we're not really there and the process has been slow? The information using a decision aid or using a tool should be presented to patients that does not use numbers or math in any way. It's virtually impossible to go in concerned about your health and being asked to interpret values and statistics that most people are unaware of. And secondly, it's always good to tell people what the benefits and risks are of medication or of surgery or of screening tests or other types of medical intervention. And the format must be clear and it must be straightforward, and we should always, as I mentioned a moment ago, use absolute values, and the denominator should be 1,000. So when you're talking about benefits and risks, most people can see 1 in 1,000 or 10 in 1,000, and that's an important point. Now, all these points I'm making are not my idea. All these points have been referenced in extensive review articles from Cochrane studies, and these are the things they say are necessary for a decision aid that can really make us get to the next level, for a universal decision aid. But unfortunately, that hasn't happened. And it hasn't happened because what has been missing in all the decision aids that you see, although some of them are sophisticated and very well put together, is the lack of familiarity. And by lack of familiarity, I mean a patient has to see, and you as a doctor has to see, how this can impact them immediately. And how do you get that? And you don't get it by having rectangles and squares, and you show dots in those rectangles and squares because people can't really relate to what that means. It reminds me of a Far Side cartoon when the owner is saying blah, 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 ginger, blah, blah, blah. And so if a patient goes into a hospital and he thinks he may have heart disease or cancer, what he hears is heart disease, blah, blah, blah. And he has to have something that gets back to a more real level. So we thought that a theater seating chart would be the way to go. Everyone's been to a theater, everyone's been to a concert, everyone's been to a ball game, and we can sort of place ourselves directly in that theater, and we can see how that will relate to what we're doing. So, let me see here. Okay. So we developed a theater of 1,000 people. It's a hypothetical theater, but we thought it would work well in discussing health benefits and risks. And we call it a benefit risk characterization theater. And as you can see, I think you can see that, that's a theater with exactly 1,000 seats. And these seats represent individuals, so these are absolute numbers. We talk about a whole population. And so if 2 people benefit, then there'll be 2 of those seats will be blackened in. For example, if you look at the theater on your left, there are 3 blackened seats. And so let's say, for example, that those are the benefits from taking a cancer drug. You can also see on the other side, which represent the risks, that there are about a third of those seats are blackened in. So in that sense, the drug is going to be helpful for 3 people out of 1,000, but it won't be helpful for 300 or so out of 1,000 because of the adverse effects. And you and your patient can sit down and talk about this, and you need qualitative information. But with this information, a patient can see intuitively, immediately, whether the risks are better than the benefits, and you can turn it around the other way. where the slide on your left has 3 blackened seats, and those are the risks, whereas the benefits look extensive on the other side with about 100 of those, or 300 of those seats blackened in. So we think this is a very intuitive way to move forward, and we think it's a way that doctors can communicate and effectively facilitate communication between patients and doctors. Could I ask, I'm going to talk about relative and absolute risk in a moment, but we have a video which does a much better job than I could do it, so that if someone could turn that on, I'd appreciate it. You can see how relative risk can distort the real benefits and risks of something like having mammograms, because they only use as the denominator, a very, very small number, because that number is compared to a group that has had another very small number, and it's 4 versus 5, which is 20%, but it's still 1 in 1,000. And patients should only see that 1 in 1,000 because epidemiologists doing cohort studies should be using relative risks and risk ratios, but not doctors when they're communicating with patients. So what I'd like to do in the next few minutes that I have at least is talk about atrial fibrillation. And the question is how do patients determine if Coumadin is right for them? And the reason I'm using this as an example is back in November of 2015, I had a heart attack, and I was told that I had AFib. And I was told I needed to take Coumadin. But I asked a few questions, and I asked them, could you please give me the relative and absolute values, but preferably the absolute values about how much benefit will be available to me? And I got a blank stare. I said, well, I was just wondering if you could tell me the difference between people who take Coumadin and don't take Coumadin and get the absolute risk reduction so that I would know whether the number was meaningful. And I still got a blank stare. I was told that Coumadin is necessary if you want to prevent stroke. And I said, and I'm not being glib here, although it sounds like it, the question was, the answer was, excuse me, you know how serious a stroke is. And I told him not as much as you did, but I really need an answer to some of these questions because I've co-authored a book recently and I have chapters on this stuff, and come on. So it didn't go too far. And I was told by a number of people independently that I really needed to be on Coumadin. So the final question I asked was, you know, I'm already on Plavix and aspirin. I drink half a bottle of wine a day. And you're suggesting another blood thinner. What would be the risk from that? And they said, I don't think you understood us. We told you already that having a stroke is really not a good thing. So I was in touch with Andy. Andy happens to be my personal doctor as well, and he was giving me advice as I was groggily going through these sessions. But the standard is that you have to treat patients with AFib using anticoagulants, such as Coumadin or warfarin, and these medicines can be dangerous, and even though they're dangerous, it's best to go ahead and take them anyhow, because in the long run, it's in your best interest. So we wrote an article in JAMA called A Grateful but Passive Patient. It was referring to me. Andy and I co-authored it. And we talked about some of the things that happened and how I felt and why they happened. And we talked about the Coumadin experience as well. And although this is all interesting because I was lying on a bed thinking, my goodness, I've written a book about it. Should I listen to these guys or not? I don't really think they're sure about what they're saying. I don't think they're talking to me about uncertainty. But what the doctors usually say, what they said to me when I'm looking down at this, because I have to read this, is that if you have AFib, which can increase your risk of stroke, with Coumadin your risk of stroke is reduced by 50%, and therefore the benefits are significant. Now those are relative numbers. They're meaningless numbers when talking to someone like me in that state. And I said to them, you know, you're using relative numbers. And again, there was no response. And I said, there are downsides to the potential serious bleeds, and your blood has to be monitored periodically, but the benefits clearly outweigh the risks. I brought up the question again, and it was ignored again. So what we did, our book contains some of this information, but Andy and I went back to see what was really going on. So here's a theater that shows 6 blackened seats, and it talks about the benefits of Coumadin. And in this theater of 1,000 people, with if they will take Coumadin, approximately 6 will avoid a disabling stroke compared to 1,000 people who take aspirin in a given year. So I was looking at that and, okay, what about the other side? What about the risks? So the risk of Coumadin has 12 seats in it. And these seats designate the risks associated with bleeds. And you can see here that 6 of those bleeds will be in the brain and cause death. So, the option was essentially dying, getting a stroke or a bleed. It was about the same. I really didn't know what to do. And then we thought, well, what the hell? Let's think about your situation, your specific situation. You're taking Plavix and you're taking aspirin. Let's see if we can find some data which compares that plus Coumadin. And that's the information. The information shows another theater of 1,000 people, and there are 70 more of them will suffer major bleeds if they take Coumadin with Plavix and aspirin. And that was recommended to me by every surgeon, every individual in the hospital at that time. So that's 7 out of 100, that's 7%. And I made the decision in collaboration with Andy that I didn't want to take that risk. So I didn't take any Coumadin. But it would be nice if all of this kind of information were available to patients all the time. It's not hard to do these theaters. It's not hard to prepare them and to communicate the information so that both you and the patient understands exactly what the issues are. And more specifically, what's really important here is that this decision it's a patient-oriented decision. It's not a medical decision or a scientific decision or an analytical decision. It's how risk-averse you are. And we're all different. And we all have a right to be as risk-averse or not risk-averse as we wish to be. And that should be the focus of what we do or don't do, as long as doctors are giving us the right information. And with that, I'm going to turn this baton back to him.
So far, the decision about Coumadin is working. We'll see how it goes. And what Eric didn't tell you is he left the hospital on potentially 5 or 6 medicines that he was told he had to take for the rest of his life, maybe more, including high-dose statins, 2 other medicines that lowered his blood pressure to 90. He couldn't get up the steps. He was dizzy. He was told he probably needed a stent put in one of his arteries that had nothing to do with his heart attack. He chose not to do that. He's now on 2 medicines, aspirin and low-dose statin, and no stent. So, we're hoping we're right. I wanted to talk about the use of these theaters in things that might be related to healthcare reform. Interestingly, I'm using EKG as an example because the insurance companies were really focused on that when we talked to them. They felt like, especially for self-insured, people were constantly asking for EKGs. And for that matter, in my community where I work, cardiologists are ordering stress tests pretty much every year on asymptomatic people. And my patients come back and talk about how thorough the cardiologist is for doing this. But my patients frequently ask, as part of their physical exam, whatever that might be, that they should get an EKG. They've always had one. So I've used these theaters to dissuade people. So, the information about EKG, and you could even look this up in the U.S. Preventive Service Task Force, which has a lot of good information, but patients that I have don't really understand it, is that if you take an EKG on top of the clinical information you already have, it adds no value. It will pick up no information that you can't get from your own clinical information, and it will save no lives. And this, by the way, is true of a stress test. Even a stress test with thallium in an asymptomatic person has never been shown to save lives. However, an EKG has an incredibly high false positive rate. About 800 out of 1,000 EKGs that are abnormal in a normal heart. And so when you get an abnormal EKG, what do? And very often a cardiologist will send them for a stress test. That will also have a similarly high false positive rate. They may then go for a catheterization. I just watched my father go through this dance, and my father used the thorough word again. And the doctor was considering putting a stent in something that was barely blocked, which is where I put the brakes on. But this is what happens when you have a test that is very inaccurate, like an EKG. You'll end up getting false information that will lead you to further testing, perhaps treatment, and you'll cause harm. And the theater to the right actually shows that there's 20 serious consequences that occur out of 1,000 people who get an EKG without symptoms. And those could be stroke, heart attack, or death. Major complications. So it's something I have to explain to my patients. They say, what's the harm of getting an EKG? There is a harm in getting tests that actually are very inaccurate, which are what most tests are, and using them just in screening in people who don't have symptoms. And my ability to use these theaters has been very helpful for me to dissuade patients even from getting their annual stress test. What if I have a normal EKG? A lot of people say to me, I just want to make sure I'm okay, so I'm going to have a normal EKG. So this is how many people who have had a heart attack would have had a normal EKG the day before their heart attack. So having a normal EKG doesn't tell you anything. You could get that normal EKG, jump up and down, and have a heart attack on your way down. Because most, and this is true of stress tests too, most heart attacks occur in places that are not blocked more than about 20%. You know, they're minor blockages. And those won't be picked up by EKGs or stress tests. And that goes to another point that I always bring with my patients, which is if something is blocked, a lot of times the cardiologist will say, we're going to put a stent in that. Now, Eric had a stent put in because he was having a heart attack. And I call that symptomatic. That was the biggest symptom you could have. A lot of my patients get stents put in without any symptoms. I had someone recently who came to me with a cough and a little chest pain from the cough. And you know, we were doing all the usual stuff for that, but he saw his cardiologist. The only reason he was seeing a cardiologist is 5 or 6 years ago in the emergency room he had a murmur detected, so now he was going back for annual echocardiograms. The cardiologist said, well, let's do a stress test. Next thing you know, he had a stent put in a 70% blockage. He came back to see me and he was still coughing. So he was wondering what was going on. And now he was on Plavix and aspirin for at least a year, which confers a risk. So when I told you about the fact that most heart attacks occur in non-blocked arteries, would indicate if you fix a blocked artery, you may not prevent a heart attack, and this is what's been shown in the literature. So in asymptomatic people, people who get stents put in arteries that are not the left main or proximal LAD, there is actually no benefit over just taking an aspirin and a low-dose statin. So you're getting no benefit in terms of the major outcomes, which are death and heart attack. However, in people who get stents, there can be severe complications. So approximately 20 of those people in the theater will have major complications from the stent itself, whether it's a major bleed, whether it's a complication from the stent not working, closing off. You could have much worse outcome having the stent than not having a stent. And when we talk to insurance companies about this, my question is, why are you paying so much money for these stents when, in fact, it confers no value and actually can cause harm? And that's the way it's always been. Cardiac stents cost about cardiac revascularization costs about $50 billion a year. Bloomberg News estimates $2.4 billion spent on unnecessary stents, and that is really a lowball figure. There are a lot of people who would give a higher figure than that. We found a couple studies that looked at how many cardiologists recommend stents with a discussion. It's about 25% of cardiologists typically discuss the risks and benefits of stents before offering them. Most people just said, you need a stent. That was the discussion. And most patients inherently believe, like what I talked about earlier, if you could feel something's right, it's right. So they inherently believe if you open up an artery, that makes you better. So again, using the theaters can help people see it a different way. There's a test that Medicare has recently offered to pay for, which is CAT scan screening for lung cancer. And it's an expensive program that has been studied. There was one big study recently that suggested a 20% reduction in lung cancer death in people who got this test versus people who didn't. And that was over 5 years. So you'd get the CAT scan every year. The study was done after 5 years, and you saw how much the reduction is. But again, that's a relative benefit. The real benefit is 3.3 out of 1,000 people who had this test compared to people who didn't averted a lung cancer death in 5 years. Now, so again, it depends on what you think. As a 50-year-old smoker, which is what we're talking about getting this test, is that enough for you to get these annual tests? Does that give you, is 3.3 something you say, yeah, I could be one of those seats? Some people yes, some people no. It certainly feels a lot smaller than a 20% risk reduction. These are inaccurate tests, very inaccurate. And approximately 675 out of 1,000 people over those 5 years will be told at least once they have an abnormal CAT scan. Some of them will be told we'll keep an eye on it, but you might have cancer, you might not. But we'll keep an eye on it, we're checking you again next year. Others, though, have to go for other testing. So in this big study and some subsequent studies, 233 needed additional testing, typically with a PET scan, sometimes with a biopsy, and there were 9 people in this cohort that were harmed over the 5 years from this additional testing. Popping of the lung, infections, pneumonia, things that can come from biopsies. But even beyond the harm, to show people the entirety of the information, there are a lot of people who say, I don't want to live with that uncertainty of knowing I might have an abnormal test and I don't know what to do about it. That level of stress is not something a lot of my patients often want to accept. And I have to say that I've had very few patients who are willing to go through this test after that I show them these theaters. There's another option for the 50-year-old smoker. If a 50-year-old smoker simply quit smoking, at age 50 there are approximately 200 deaths averted in the next 25 years just from quitting smoking. And how much does that cost Medicare? And what are the side effects? How many people are harmed from the process? And there should be a couple CEOs from the tobacco companies in there. They get harmed, but again, to juxtapose the lung cancer screening with the smoking quitting has convinced a few of my patients to quit smoking because they came in gung-ho to have this test, and when they see this other thing, they realize just how absurd it is for them to continue to smoke. And I was telling Eric, when you talk about a lot of people don't understand risk. I have a lot of smokers who continue to smoke, but they won't go down to Florida because they're afraid of Zika. There's this, and sometimes you have to, with smokers especially, show them the numbers compared to something else. So lung cancer screening, Medicare estimates that it's going to cost about $9 billion a year. Again, not an insignificant figure. Less than 50% doctors in follow-up studies actually did discuss the risks and benefits. And by the way, Medicare mandates that you discuss the risks and benefits. This is the only test Medicare mandates you do it. They do not give you how you do it, so a lot of people in this study discussed it by saying there's a 20% risk reduction and there are some side effects, which is how a lot of people do. Again, emphasizing the benefit and the risk. And of course, the cost of smoking cessation is not bad at all. So clinical guidelines I talked about a little bit, and can these theaters be used for that? Again, clinical guidelines are based on information that's very generic and doesn't apply to your specific patient sitting in front of you in the room. There's a medical, I'm a geriatric doctor. I take care of a lot of very old people. And in my book, Curing Medicare, I tell a story about someone from the Orange Clinic who I took care of, and Gene Corbett probably doesn't remember this because it was a tough story. Old guy on a farm in his 90s, and I went out there and his blood pressure was out of control high, 220 over 110, something like that. And I had just read the SHEP study, which was a new study that said systolic blood pressure that's high in the elderly will cause strokes. And I came back to Gene and John and I said, we got to treat this guy. And they said, you know what? No big deal, just relax. He's okay, he's still farming, but I insist on it. They let me put him on, I think, a low-dose beta blocker or maybe hydrochlorothiazide, and I was going to check on him next week, and he died. Now, whether he died because he needed every bit of that blood pressure to get into his narrow arteries, he needed 210, his body was doing him a favor, and I the brilliant doctor, resident, said, no, that doesn't fit with SHEP. Shows you just how we have to view everyone individually. And especially in very old people, I've found that high blood pressure is crucial to their very survival. That if you get their blood pressure down in normal range, they get confused, dizzy, they fall, they're tired all the time. They have one of my favorite patients who died recently, well in her 90s, exercising every day, typically had a systolic blood pressure in the mid-200s. And every time she saw someone else, they kept trying to get her down and she ended up in the emergency room. So we have to, and clinical guidelines do not allow us to have that flexibility. So the SPRINT study, which a lot of people are aware of, suggested in older people who are high risk for heart disease, there's a 20% reduction in death with aggressive blood pressure control, which is blood pressure below 120. And Medicare has adopted that as one of its clinical guidelines. I have to indicate that if my patient's blood, my 99-year-old's blood pressure is above 120, I have to give a plan of what I'm going to do to get it below. If it's above 140, then I actually get dinged as failing the guideline. So what did the study really show? So in people with high risk of coronary disease, and it was a very skewed study that I talk about a lot in some of my blogs, 3.5 deaths were averted in a year in people who had aggressive blood pressure control. In that same group, there were 20 severe life-threatening side effects, which the article poo-pooed, if you read the article. And if you look at other studies that preceded and came after the SPRINT study, there were actually, in people who had aggressive blood pressure controls in other cohorts, not people with severe high-risk coronary disease, there were 8 to 10 additional deaths in this group when you had blood pressure lowered too much. So this was not a consensus study. The ACCORD study, the HOPE-3 study, which came after SPRINT, and a large VA study in people with renal disease all showed a higher death rate in people who had aggressive blood pressure control. And SPRINT had about 3,000 to 4,000 people in it. These studies collectively had well over 100,000 people. And yet Medicare's guidelines still insist that we do this. A lot of people know ACP, American College of Physicians, and American Associated Family Physicians have changed their tune and have gone against that guideline. But as I'm doing my quality indicators, as I do every day, Medicare hasn't changed at all. So using these kind of theaters to look at all the quality indicators and then actually individualize for patients would make sense, and perhaps our quality indicators would be much better judged if it just allows us to have a conversation. So with this example or with a mammogram example, as long as we can prove we had the conversation, then perhaps that alone is the indicator. The patient can decide what he or she wants to do. We've conducted focus groups. Now, there are our own biased focus groups, and we provided food so people were happy. And so they may have just done what we said, but we thought they were relatively reasonable, and people were very turned on by these theaters because they immediately saw what risks and benefits were. We showed some drug ads, we gave some numbers that were in the newspaper recently, and then we showed them the theaters and they saw the difference. And they really felt the familiar setting, when we asked them at the end, was the most important part. They could actually see themselves in the theater. Certainly the theaters in the Kaiser Health video that we showed were a lot more graphic, and if we could do those all the time, that would be wonderful. One caveat was there's something called number needed to treat, which a lot of people use, and we threw that out there too as a possibility. People were utterly confused by number needed to treat. The patient, they did not know what that meant. When we said 6 out of 1,000 people get strokes who are on Coumadin compared to aspirin, and then we did number needed to treat. If you treat 120 people, then one person will avoid a stroke. This was too much. So we really felt the number needed to treat too numerical. People don't like that. So the benefits, the benefits we've discussed already. The biggest thing we have found is that this allows us to have shared decision making that puts the patient in a seat that the patient deserves to be in. A patient who can understand what's actually going on and gets in actual information. And to avoid some of this over-testing and over-treatment that is listed below, like the guy going to the perfectly healthy but worried about cancer window, or a lot of those screens where you see they check your carotids, your abdominal aorta, and your legs for $100. And I thought this was just funny, so I put it in. They found cholesterol pills and clogging up his arteries. It's probably what's going on. So creating sensible clinical guidelines, incorporating this into electronic medical records, we think would be very important. So as the guidelines come, the theater comes right up. And you could go through it, and then you indicate you had the discussion. Using this to change to a value-based payment system. So, instead of paying doctors for low-value care, lots of money, You pay doctors for high-value care, lots of money, like primary care doctors. We give the highest value care, that's just a fact. It could be used in the media. We've talked to a place like the Baltimore Sun, and we said, whenever you publish a health article, put one of these in. Because then you can really see what's going on, but that's not going to make front-page news. The Sprint study makes front-page news because it showed a 27% reduction in death. You see those 3 little seats, that's going back to page 20. And we thought creating a patient-oriented website would be a very good idea. So lots of further study could be done with this. How much acceptance does this really have? If you did a big kind of group analysis, will it actually reduce overtreatment? There is some evidence that decision aids do reduce overtreatment. What's the best way to utilize it? Is it having a website? Is it having doctors initiate it? How could they be easily customizable? Because we know, for instance, someone with a strong family history of breast cancer will have a different theater than someone with no family history. So we need to be able to customize it. And measuring the intensity of effect, because as Eric said, dying versus having a hangnail are 2 different things, and it's important to distinguish those. So that we do have a blog, and every time a new article is printed, we'll throw a theater up on the blog just to put it in that format. And we do also go through cancer screenings and other things periodically just to look at what's newest out there. So questions, I guess.
My name is Ross Buron, and I'm one of the chief residents for the Department of Medicine. And on behalf of the Department of Medicine, thank you both for coming and for your talk. As healthcare providers, we seek to form a unique relationship with our patients during a pretty vulnerable time in their life. And they often grant us a bit of an omnipotent trust during that time. And I think it's up to us to form some shared decision-making models and improve our communication with them during those times. Your models definitely highlight the importance of that, so thank you. And if anybody has any questions, I'm happy to bring you a microphone.
I can speak up. I'm Daniel. I'm one of the third-year medicine residents, and I'll be doing a lot of screening colonoscopies next year, of course, which are of very benefit. But I was more curious about, there's a website, the NNT. I don't know if you guys were familiar with that or had any thoughts about it. But it's basically a look at the number needed to treat for a whole lot of common conditions. I don't know if you had any, if you thought it's useful, not useful.
I do. I know the NNT very well. I know the person who does it. He's part of a group called the Lown Institute. He works with the Lown Institute, which I encourage all of you to join because it deals with this issue. The NNT has terrific information in it, and in fact, some of the information that I obtained when we wrote the book was from that website and from talking to him. The concern I had with it was, number one, it looked at information 2 ways. One was number needed to treat, and the other one was similar to more of an absolute risk benefit. You could click to either one. Very wordy and not very pictorial. And I showed a lot of my patients that site, it was just too much for them. I think as a doctor, it was helpful to me. But again, it lost the familiar setting that I found is most useful for the patients.
Just one addition, the number needed to treat is a reciprocal of absolute risk reduction.
Right.
So they both are accurate and use the number, that the ability for patients and doctors to communicate using that technique is a little bit difficult.
Absolutely. I think it's more of a provider-oriented website than it is a patient-oriented, although they were a little more optimistic about Coumadin than I think you guys were.
No, actually, no. A lot of what I got was from that site. If you look at the absolute, it's very similar, and you have to understand that the difference that we have on ours is our strokes that actually persist, what are called disabling strokes. So if you actually say just strokes, they get better tomorrow, then your numbers are going to be higher. That's like a lot of the studies that have looked at bisphosphonates for spinal compression fractures, look at compression fractures that nobody ever knows even exist. If you start distinguishing from painful compression fractures, your numbers are a lot smaller. So we felt it incumbent upon us to look at things that actually impact patients.
Andy, can you have a discussion with the patient? You say there's relative risk, here you are in the theater, and they make a choice for non-intervention, but yet something bad happens, which is going to
Yeah.
happen, what's your discussion with the family or the patient themselves after that?
You know, I'll always, when I have the discussion, say that something bad can happen. And, you know, for instance, Coumadin is a big example of that. You know, you might have someone who, you know, I've done enough of this, it hasn't happened yet, that someone might get a stroke when they decide not to take Coumadin. But I make it very clear at the beginning that this risk exists, and that, you know, it's up to them which risk they prefer. You know, if we knew which risk we were actually going to be hit with, that would make the decision a lot easier. And that's true. You know, bad outcomes occur. You know, people who have chosen, you know, Eric, you're talking about colonoscopy. We have data on that. I looked at the data and decided to get a colonoscopy. Eric looked at the same data and decided not to. You know, if Eric gets colon cancer, will he kick himself? If my colon pops from the colonoscopy, will I kick myself? The point is that bad outcomes can occur either way. And we have to let them know with intervention too. If we push Coumadin and they bleed in their brain, you know, we have to make that very clear also that that can happen. So I make it clear that whichever choice you pick might be the wrong choice. You know, I wish you'd do it.
When it happens, you find that you lose that patient?
I don't. I actually find, because we had that discussion beforehand, it's actually something that people appreciated, yeah.
Thank you for your talk. It was great. I'm one of the hospitalists here. So my question is, how do you partner? Do you partner with the consultants in the community, in that, you know, some of what you're potentially recommending or sharing with patients may be contradictory to the thorough cardiologist or gastroenterologist or whoever, and so are you making connections with those specialists with this information to make sure that you're in some ways on common ground and that you're not somewhat adversarial with the patient in front of you, so that you share trust as opposed to losing it?
I think that's a great question, and that's a question that's been, in my practice, very difficult. We have a group of very aggressive cardiologists where I work that literally stress test, echo, and Holter everyone once a year and do a lot of stents. And my patients and these people over the 7 years I've had my own practice know me pretty well. So the relationship they have with me might be different than the relationship they have with other doctors, because my patients walk into their office with information that they give them, that I say, have the doctor explain it to you. So I said, my relationship with them is through my patients. I say, your cardiologist has an obligation to explain to you why he or she is doing this test and what the outcome is going to be if you do it and if you don't do it. Here's the information I have. I show them, we have theaters on all this. And I say, so if they have different information, I'd be interested in having that information. And I've seen the cardiologists doing much fewer tests on my patients. They don't want to do that. So I don't know, I mean, I think I have a great relationship with the cardiologists in town, but they kind of know where I'm coming from. And that's helped. I think just as a primary care doctor, just being pretty bold, and I believe as a primary care doctor, I can take care of pretty much everything other than intensive care that patients run into. And I feel like I have every right to talk about the cardiology world as the cardiologist, and I make that very clear to them. And that's worked. I still have a great relationship with the cardiologist. And my patients sometimes hear two different stories. And I'll say, well, there are two stories, and then here's the facts, and you can make your decision. And a lot of them do choose to continue getting the annual stress test. It makes them feel good, even though deep down they know. You know, I had someone recently wanted a PSA, even though we've had this discussion. And they said, look, if it's normal, I'll feel so good. And I said, well, what if it's not normal? And probably you shouldn't feel good if it's normal either, or any more normal. They said, I just will feel good if it's normal, just do the test. And, you know, we're not rational creatures, as I started with. So you have to work with patients. But the specialists, not all specialists are like this. The person in charge of this institute, the Lown Institute, which deals with overtreatment, is a cardiologist. So, you know, you find the ones who are willing to work with you, too. And that's really important also.
Time for one more question.
Thanks,
Mike Williams, I'm actually a surgeon, so forgive me, all of you.
If we were on an island deserted, I want you there, not me.
I've been that guy. So my question is, and love this information. I love the perspective you guys have provided for us, and I'm hopeful that we can find a way to disseminate this across the country, because we need to, obviously. My parents and I are having this talk about unnecessary testing that they're undergoing, and they're in their 80s, and I'm like, you know, if I get to be 70, I've had my last colonoscopy, because whatever happens after that, that's what's going to happen to me. But my question is, there's one risk that we haven't talked about, that I haven't heard mentioned today, and increasingly as insurers shift costs back to individual patients through their employees who can't, or their employers who can't afford the healthcare premiums, those costs shift back to individual pocketbooks. One other risk, one other black dot, is how much it's going to cost me, the individual, for the test. Because increasingly, I got to pay for the test, which I'm okay with. Like, I think that's part of why we have the problem now, is get a test, because somebody else is paying for it. And so I'm wondering if you have considered the possibility of adding in the direct or indirect costs of all these tests people get to them as one more piece of data they can use to make a decision about what the value is in the test.
Well, there's certainly a lot of people in the political world who have talked about that, from the right and the left. Paul Ryan talks about that all the time and believes, I don't agree with everything the man says, but he does believe patients should have a stake in everything they do. He's even talked about getting rid of the 20% copay that you can get, I mean 20% secondary insurance you can get with Medicare, because he says it takes that away from patients. The patients can make a better decision if there's money involved. And yeah, that may well be part of the equation too. That they're much more willing to look at this pros and cons. Again, I found in my own practice, even in the Medicare world I live in, where most of my patients have secondary insurance, that they still don't want a lot of testing, and they're looking for any way out of it. And this actually gives them the freedom to move on and say, I don't need that. So even without the money part, I think this has been very, very helpful.
I'd like to thank Andy Lazarus and Eric Rifkin again for a wonderful hour. I'm sitting here thinking about clinic rooms with pads of paper that have the theater on it and Sharpies, so you can color in the
Would be great.
squares. We hope that you can join us next week for Medical Center Hour. The topic is ethics and emerging threats to the health of pregnant women, Zika and beyond, with Annie Drapkin-Lyerly from UNC Chapel Hill. So please join us then. And again, please thank Andy Lazarus.